Hello, this is Dr. Stanley Kim again. Today we will discuss colorectal cancer. Things are changing so rapidly nowadays, and it's so true in the field of colorectal cancer. For the last couple of years, tremendous improvements took place in the field of treatment of colorectal cancer. First of all, the paradigm of rectal cancer therapy has shifted to preservation of rectal sphincter. Traditionally, rectal cancer patients had a removal of the rectal tumor along with the anus. So they have to have a colostomy and a bag attached in the abdominal wall. With a new treatment, with a total neoadjuvant therapy and sometimes immunotherapy, patients no longer requires surgery or colostomy bag or even radiation therapy. Recently, FDA approved new treatments, new medicine for metastatic colon cancer that has progressed over previous multiple chemotherapy. We'll discuss more detail, and thank you for watching.
Colorectal cancer is the third most common cancer, and its incidence has been decreasing. However, the incidence among young people aged 50 or younger, which is called early onset colorectal cancer, is rising, especially in the left side colon and the rectum. Sugar-sweetened beverages and gut microbiome changes due to Western-style diet and obesity may be the cause. Colorectal cancer starts from an adenomatous polyp. By the way, the hypoplastic polyp has no risk. About 5% of adenomatous polyps progress to cancer. It probably takes 10 years for an adenomatous polyp to become cancer, which is the reason why we do the screening colonoscopy every 10 years. If colonoscopy found a small size adenomatous polyp, 5 centimeter or smaller, follow-up colonoscopy is recommended in 5 to 10 years. But for larger size, 10 millimeter or bigger, follow-up colonoscopy is done in 3 years. Another change is screening age of colorectal cancer. Most U.S. agencies now recommend initiating screening at age 45 through age 75, as long as the life expectancy is 10 years or longer for average risk adults. What about the people age over 75? It's an individual decision. What kind of screening methods are used? Colonoscopy every 10 years. But a recent large European study showed that the benefit of screening colonoscopy was smaller than that of previous thought. The risk of death from colorectal cancer was 0.28% in colonoscopy group and 0.31% in the usual care group. The difference is only 0.03%. Other methods include Cologuard, which is multi-target stool DNA test every 1 to 2 years, but mostly every 3 years. It has high sensitivity in detecting colorectal cancer, but has higher false positive rate at 12%. It's more expensive and is not indicated for high-risk patients who has family history of colorectal cancer, inflammatory bowel disease like ulcerative colitis, and the history of polyp. Another test is a FIT test, fecal immunochemical test, done every year. There is no real difference between FIT and the Cologuard in detecting colorectal cancer, but FIT test is cheaper. The medical reimbursement rate is $24 versus $121 per test. But the specimen should be returned within 24 hours. Cologuard in 3 days. Other test, Guaya fecal occult blood test, which has a lower sensitivity and the specificity. But test has to be done for 3 consecutive bowel movements. Should avoid the red meat and the large dose vitamin C because they may cause false negative results, and also avoid non-steroidal anti-inflammatory drugs for 7 days prior. But aspirin once a day may be permitted. CT virtual colonoscopy is done every 5 years for older patients with a comorbidity. However, capsule camera colonoscopy is not recommended screening test, but approved for follow-up test for incomplete colonoscopy. If the non-invasive tests turn out positive, then colonoscopy should be done in 3 months. Colorectal cancer staging is the same. T1, tumor invades the submucosa. T2 invades muscularis propria. T3 invades through muscularis propria into subserosa. T4 directly invades other organs and or perforation of visceral peritoneum. N1 means 1 to 3 regional lymph node positive. N2, 4 or more lymph node positive. Stage 1 means small tumor without lymph node metastasis, T1 or T2. Stage 2, larger tumor, T3 or T4 without lymph node metastasis. If there is any lymph node metastasis, it's stage 3. Distant metastasis means stage 4 disease. When the biopsy confirms the cancer and there is no distant metastasis, resection of colon is the next step with open colectomy. However, laparoscopic colectomy shows the same 5-year survival rates. At least 12 regional lymph nodes must be dissected. Fewer than 12 lymph nodes dissection is a high risk in stage 2 and cause high recurrence rate in stage 3. Sentinel lymph node sampling, like a breast cancer, is not a standard method because of high false negative rates. About 5% of polyps contain cancer, which is called malignant polyp. High-risk polyps need radical surgery, which include poorly differentiated adenocarcinoma, lymphovascular invasion, cancer or dysplasia at resection margin, or a T1 or T2 tumors. Types of surgery include right hemicolectomy for the tumor in the right or ascending colon. If the tumor is just beyond the right colectomy surgical line, then extended right hemicolectomy is done. The same as left hemicolectomy and the extended left hemicolectomy. Transverse colectomy is done for a really mid-transverse colon, which is not done commonly. Segmental resection for splenic flexure tumor, and the sigmoid resection for the sigmoid cancer. And for the cancer in a patients with a familial polyposis or ulcerative colitis, then total proctocolectomy is recommended. So ileal pouch anal anastomosis is created. The type of rectal cancer surgery depends on the location of the tumor. If the tumor is in upper 2/3 of rectum, which is usually 5 centimeters above the anal verge, low anterior resection is done. Diverting ileostomy, which is temporary, may be necessary to prevent anastomosis leakage. When the tumor is located in lower 1/3 rectum, 5 centimeters within the anal verge, abdominal perineal resection is the choice, which sacrifice the anus. So patients need to have a colostomy bag. But for smaller lesions, T1 and 0, well-differentiated tumors, less than 3 centimeter size, and involvement of less than 30% of lumen circumference, not fixed tumor, local excision can be done, which include endoscopic resection for mid to proximal rectal lesion, and transanal excision for distal lesions. Please look at this picture, the endoscopy resections. The Endoscopically, the gel or normal salines are injected around the tumor to raise the tumor, so it makes it easy to excise the tumor. Majority of colorectal cancers are adenocarcinoma. There are 4 grades depending on the gland formation of the tumor. Grade 1 is well differentiated, over 95% are gland-forming tumor. Grade 2 is moderate differentiated, Grade 3 poorly differentiated, and the Grade 4 undifferentiated. DNA mismatch repair, MMR gene mutation, and the microsatellite instability, MSI, should be checked with the colorectal cancer specimen. If deficient or MSI high, which means somatic mutation, which occurs in about 15% of all colorectal cancer, then blood test for germline mutation of MMR should be done. The germline mutation of MMR is the cause of Lynch syndrome, which is hereditary non-polyposis colorectal cancer syndrome. There are several non-gland forming colorectal carcinomas. Mucinous carcinoma accounts for 11%, produces extracellular mucin in more than 50% of the tumor mass. More common in the right colon cancer, may not respond well to chemotherapy, which indicates poor prognosis, although it's somewhat controversial. But a study reported that poor prognosis is only seen in the rectal cancer only. Signet ring carcinoma is rare, produces intracellular mucin. It has poor prognosis and a high incidence of MSI and the Lynch syndrome. Medullary carcinoma has a good prognosis instead. It has eosinophilic large cells with a heavy tumor infiltrating lymphocytes. It has a high incidence of MSI high and the Lynch syndrome. Generally, microsatellite instability are more common in the right side of colon cancer, and the more common in the mucinous signet ring and the medullary carcinoma. When patients present with a metastatic carcinoma without obvious primary lesions, immunohistochemical study may help to identify the origin of the tumor with the CK20 and the CK7. In colorectal cancer, CK20 is positive but CK7 negative. In mucinous ovarian carcinoma or urothelial bladder cancer and the pancreatobiliary cancer, both CK20 and the CK7 are positive. Adenocarcinoma of the lung has a CK20 negative and the CK7 positive. Renal cell cancer, prostate cancer, both neither CK20 nor CK7 are positive. I'd like to mention that loss or lower CDX2 staining of colorectal cancer is associated with the poor prognosis. There's no major changes in adjuvant therapy. For stage 2 tumor, no adjuvant therapy is necessary unless high-risk features are present. What are high-risk features? T4, poorly or undifferentiated histology, less than 12 lymph nodes in the surgical specimen, lymphovascular or perineuronal invasion, higher levels of tumor budding, which means presence of single tumor cells or small clusters of up to 5 cells in the tumor stroma, clinical obstruction, or colon perforation. Patients with the MMR deficiency tumor have a better prognosis, so there is no need of adjuvant therapy for stage 2 tumor. But if other high-risk features are present, then it's an individual decision. Oncotype DX colon recurrence score, which is a 12-gene assay in stage 2 colon cancer, has been validated in predicting recurrence rate, but it does not predict response to adjuvant chemotherapy. So NCCN guideline does not recommend it as of March 2024. Chemotherapy regimens are usually 6 months of 5-FU or capecitabine. But for high-risk features like a T4, Capox for 3 months or Folfox for 6 months. For patients with a positive surgical margins or ascending descending colon with the penetration to the fixed structures or abscess formation, which is T4B, adjuvant radiation therapy may be considered, but it's still controversial. It may not help. Capecitabine requires dose reduction by 25% for the GFR 30 to 50, the renal dysfunction, and the no proton pump inhibitors like Prilosec, omeprazole, because it causes poor absorption of capecitabine. For stage 3 disease, adjuvant chemotherapy should be initiated within 6 to 8 weeks of surgery. Efficacy decreases after 88 weeks. And there is no effect of adjuvant therapy if it's given beyond 6 months after surgery. The chemotherapy regimen includes Capox for 3 months. For high-risk disease, 6 months of FOLFOX. But if it's low risk or T1 to 3N1, 3 months of FOLFOX is as good as 6 months of FOLFOX. If neuropathy develops after 3 months of FOLFOX, then 3 months of FOLFOX plus 3 more months of 5-FU leucovorin alone. For frail or unfit patients, oxaliplatin is not given unless the tumor has a positive MMR deficiency, because MMR deficient tumor is resistant to 5-FU. So we have to give oxaliplatin at lower dose. Adjuvant radiation therapy for high risk of local recurrence is not conclusive and controversial. I would like to mention about DPT deficiency. DPT, dihydropyrimidine dehydrogenase, is an enzyme metabolizes 5-FU to inactive 5-FU-H2. So if patients have this DPT deficiency, more 5-FU will have a cytotoxic activity on the cancer cells as well as normal cells, causing severe 5-FU toxicities such as mucositis, hair loss, diarrhea, neutropenia, skin rash, neurological toxicities. About 9% of population have DPT deficiency. However, FDA or NCCN or ASCO do not support testing for DPT enzyme activity before starting a 5-FU. When severe toxicity develops after 5-FU, Vistogard, uridine triacetate is the antidote. In the past, rectal cancer was managed by surgical resection followed by radiation and chemotherapy, which means adjuvant therapy. Since 15 years ago, neoadjuvant therapy has replaced this adjuvant therapy. Neoadjuvant therapy includes the preoperative chemoradiation therapy, which provides better local tumor control and a better chance of sphincter saving surgery and fewer chronic anastomotic stricture. The indication of this neoadjuvant therapy include T3, T4 tumor regardless of nodal status. And for the proximal T3N0, upfront surgery is still an option. However, T3 tumor with more than 5 mm of extramural invasion has a high rate of lymph node involvement and the distal metastasis, so it's reasonable to include T3N0 tumor. And another indication include small tumor T1, T2 with a clinical positive lymph node disease, or tumor that appears to invade or threaten the mesorectal fascia on preoperative imaging. Even small distal tumors, T1, T2, and 0 disease, which require abdominal perineal resection, which means resection of the anus and the colostomy bag, may be included in an attempt to convert the operation to the sphincterectomy sparing surgery. So you can convert the abdominal perineal resection to lower anterior resection by neoadjuvant therapy. Total neoadjuvant therapy is another newly developed treatment of rectal cancer. This includes the chemotherapy, full dose, and chemoradiation therapy given before surgery, unlike a standard neoadjuvant therapy where the low-dose chemotherapy is used for radiation sensitizing agent. Full-dose chemotherapy is used in total neoadjuvant therapy, and the chemo and before surgery. Compared to standard neoadjuvant therapy, it may improve the pathological complete response rate, leading to sphincter preservation by omitting surgery and disease-free survival and even overall survival. The optimal method, radiation and chemotherapy administration in total neoadjuvant therapy, has not been established yet, but is still evolving. For radiation, the short course radiation followed by chemotherapy was inferior to long course radiation therapy concurrently with the chemotherapy in 5-year local regional recurrence rate, but 5-year overall survival was similar. Now let's discuss total neoadjuvant therapy clinical studies. RAPID trials is for high-risk rectal cancer, included 900 patients. They compare the short course radiation therapy followed by chemotherapy and then surgery versus standard concurrent chemoradiation therapy followed by surgery with or without optional adjuvant chemotherapy. The results at 5 years showed disease-related treatment failure, mainly distant metastasis, was higher with the standard concurrent chemoradiation therapy. But local regional failure was higher in short course radiation therapy followed by chemotherapy. And the complete pathological response rate is higher in the short course followed by chemotherapy than concurrent treatments. Toxicity is more with the short course, and the overall survival is similar. The Prodigy trial compared the total neoadjuvant chemotherapy using FOLFIRINOX with the conventional FOLFOX or CAPOX. Induction chemotherapy with modified FOLFIRINOX was given for 6 cycles for 3 months, followed by long-course chemoradiation therapy, then surgery and adjuvant chemotherapy with the FOLFOX for 3 months. Compared with the standard chemoradiation therapy, followed by surgery and adjuvant chemotherapy with the FOLFOX for 6 months. And the results at 7 years showed the complete pathological response was more than doubled in FOLFIRINOX induction chemotherapy group. Local regional relapse was much less, and the disease-free survival was higher with the induction with the FOLFIRINOX, and the overall survival was better with the FOLFIRINOX induction chemotherapy. And the serious toxicity was comparable. So the total neoadjuvant therapy with the modified FOLFIRINOX has a higher pathological complete response rate, disease-free survival, and overall survival with a similar serious toxicity. CAO-ARO-AIO-12 trial is a European studies with 300 patients, T3, T4, and or lymph node metastasis, and the tumor lower than 12 centimeters from the anal verge. The chemotherapy, FOLFOX 3 cycles, followed by long course chemoradiation therapy, then surgery was compared with the upfront long course chemoradiation therapy, followed by consolidation chemotherapy with the FOLFOX 3 cycles, then surgery. Results at 3 years showed that similar disease-free survival and overall survival, but pathological remission response was higher with the upfront chemoradiation followed by consolidation chemotherapy. toxicity was comparable, and the compliance was slightly better with the upfront chemoradiation therapy. So upfront chemoradiation with the consolidation chemo before surgery resulted in better pathological complete response rate without compromising survival. And I prefer this way of treatment. The Prospect trial is very interesting, involving over 1,000 patients with proximal and mid-rectal cancer eligible for sphincter sparing surgery, like a low anterior resection. Half of patients were given chemotherapy for 6 cycles only without radiation therapy, which was compared with the standard chemoradiation therapy before surgery. And amazingly, nearly 90% of patients who had only FOLFOX chemotherapy were able to avoid chemoradiation therapy. What if the patients did not respond to chemotherapy alone? Then they had chemoradiation therapy. But it's only 9% of patients did not respond to chemotherapy alone. I'd like to introduce the amazing landmark study called the OPERA trial. Over 300 patients with mostly stage 3 distal rectal cancer were included. They compared the induction chemotherapy followed by chemoradiation therapy versus chemoradiation therapy followed by consolidation chemotherapy, then restaged. When the patients have a complete or near complete response, then watchful waiting without surgery. For patients who had incomplete response, then they need to have a surgery. The induction or consolidation chemo include FOLFOX or CAPOX for 4 months, and the restaging is about a couple of months after the completion of chemo radiation or consolidation chemotherapy. The results at 5 years showed 40% of induction chemotherapy followed by chemoradiation therapy, and 27% of upfront chemoradiation followed by consolidation chemotherapy had a remote tumor regrowth. So much better with the upfront chemo and consolidation chemotherapy. And the proportion of patients who actually preserved the rectum was 47% in induction chemo followed by chemoradiation versus 60% in upfront chemoradiation followed by consolidation therapy. And most of the tumor recurrence occurred within 2 years, and 99% occurred in 3 years. So upfront chemoradiation followed by consolidation chemotherapy provided higher surgery-free survival with the same disease-free survival, and over 70% of good responders after upfront chemoradiation therapy followed by consolidation chemo did not require surgery. It's amazing. The Sloan Kettering Memorial Cancer Center reported 12 patients who had immunotherapy before chemoradiation or surgery with a dostarlimab 500 milligram IV every 3 weeks for 6 months. And then all patients have a clinical complete response, negative MRI, PET-CT, endoscopy, DRE, or biopsy. So no patients had a chemoradiation or surgery. Amazing. And no case of recurrence had been reported during follow-up period of 6 to 5 months. And 81% of patients showed a response within 9 weeks, about 2 months after immunotherapy. And the toxicity was over more than grade 3 was none. So immunotherapy may be the treatment of choice for the patients with the diffuse MMR rectal cancer if confirmed in a large study. For metastatic colorectal cancer, the systemic therapy is indicated. But instead of starting chemotherapy, we want to check for biomarkers,
because sometimes we can use targeted therapy, which is better in terms of toxicity and response rate compared with the chemotherapy. Those biomarkers include RAS, BRAF mutation, HER2, NTRK fusion, deficient MMR, and MSI high, and tumor mutational burden. But majority of patients have negative of those biomarkers. So we use the chemotherapy with bevacizumab for the right side of colon cancer. For left side colon cancer, we can use either chemotherapy with the bevacizumab or chemotherapy with the cetuximab or panitumumab, which are anti-EGFR inhibitors. But recent studies, very recent, show that FOLFOX or FOLFIRI with the bevacizumab trends better than chemo with the cetuximab. Has a better, longer disease-free survival with less toxicity. When chemotherapy is combined with the anti-EGFR, remember, for cetuximab, FOLFIRI is used, not the FOLFOX. And the FOLFOX can be combined with the panitumumab or panitumumab. I don't know exactly why, but the FDA approved this way. I guess the study conducted used this combination. But when the RAS or BRAF mutation positive, then never use this anti-EGFR. It doesn't work, or it may be harmful even. The anti-EGFR side effects include low magnesium or acne-like skin and itching. Some patients with a stable disease may offer intermittent therapy with several months or a year of vacation. Bevacizumab is not used for active bleeding, thrombosis within the past 6 to 12 months, or untreated hemorrhagic brain metastasis, because it can aggravate the bleeding or thrombosis. When anticipated surgery, 6 to 8 weeks after the last bevacizumab, because bevacizumab can delay wound healing. But when patients had a surgery already, at least the 4 weeks has to be waited before treatment with bevacizumab started. What about combination of chemo, bevacizumab, and the anti-EGFR? It's inferior to chemo with bevacizumab, so this triple therapy is not recommended. For positive deficient MMR or MSI-H or high tumor mutational burden tumors, we use the immunotherapy with the pembrolizumab monotherapy. It's better than chemotherapy. When the tumor still grows, progressed over all these first-line treatments, then we use the second-line therapy, which include the Stivarga or FOLFIRI with the Zaltrap, FOLFIRI with the Cyramza, and for positive BRAF mutation, encorafenib with the cetuximab, and for NTRK fusion positive, larotrectinib or entrectinib. And the FDA recently approved the new treatments, Lonsurf with the bevacizumab, fruquintinib, and for HER2 positive tumor, tucatinib in combination with trastuzumab. Low vitamin D level may be associated with a poor colon cancer related outcome, so please replace it if level is low.
I often see colorectal cancer patients who presented with liver metastasis at the time of diagnosis, or who developed liver metastasis during the course of therapy. In that case, surgical resection may cure the metastatic cancer. 5-year survival is average 40% after surgical resection. For imaging, MRI is preferred over CT, and consider PET-CT to exclude extrahepatic metastatic disease before surgery. For resectable liver lesion, surgery first, followed by 6 months of chemotherapy can be done, or preoperative chemo for 3 months up to 4 months because of liver toxicity, followed by surgery, followed by 3 more months of chemo. For total 6 months of chemotherapy is often done. In this case, please check the response in 6 to 8 weeks. If the tumor didn't respond to chemo, then we have to send the patient for surgery as soon as possible. Even if initially unresectable liver metastasis, induction chemotherapy may downstage and convert to resectable disease. In a randomized study, induction chemotherapy converted the inoperable to resectable disease in about 50% of cases with a FOLFOX or FOLFIRI, and the 57% with the FOLFIRINOX, of course with a higher toxicity. In those cases, bevacizumab or cetuximab were combined depending on the RAS status. We studied previously that when the patients have a RAS positive colon cancer, we don't use the cetuximab. For metastatic RAS or BRAF positive right colon cancer with a liver metastasis, initial FOLFOXIRI with a bevacizumab for up to 6 months was better than more milder FOLFOX or FOLFIRI with a bevacizumab. Of course with a more toxicity. In patients with a RAS or BRAF negative left side colon cancer, then we can use a cetuximab. But when FOLFOX or FOLFIRI combined with the bevacizumab was compared with the chemo with the cetuximab, there is no difference in terms of disease-free survival. But those bevacizumab group has a less toxicity. So overall, chemotherapy with the bevacizumab is preferred over chemo with the cetuximab, regardless of the RAS or BRAF mutation status. I also want to mention that there is some controversial issue, but this is the previous older studies, 2020 or 2013. If hepatic resection is planned for metastatic lesion, addition of cetuximab to chemotherapy in preoperative setting decrease the overall survival when compared with the chemo alone. Well, look, recent studies showed that combination of bevacizumab with chemotherapy was very good in converting the inoperable to operable cancer. After resection, follow up with the CEA and the CT chest, abdomen, pelvis every 3 months for 2 years, then every 6 months for 3 years. Colonoscopy in 1 year, then in 3 years, then 5 years. We have a new treatments approved by FDA. In January 2023, FDA approved the combination of tucatinib with the trastuzumab, which is Herceptin, for HER2 positive but RAS negative advanced colorectal cancer after failure with at least 2 prior treatments. This is based on Mountaineer trial. The overall survival was over 2 years, very impressive. In August 2023, FDA approved Lonsurf in combination with bevacizumab for metastatic colorectal cancer previously treated with a maximum 2 prior chemotherapy, which is based on a Sunlight trial. The overall survival was about 1 year. In November 2023, FDA approved fruquintinib. Fruquintinib is an anti-VEGFR TKI as a second-line therapy based on FRESCO trial, and the median survival was 7.4 months. I like to deliver a message to all cancer patients. There was never a night or a problem that could defeat sunrise or hope. Thank you for watching.